Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric. This week, I am with Alfredo Leal. Alfredo has been coming to the college for almost 10 years now. He's our first student to get through the Masters of Austere Critical Care program, and you will be defending your thesis in a fortnight. Alfredo, welcome to the program.
Thank you, Eric. It's a pleasure to be here.
So you were one of the originals. Was it like 2014 that I first met you in Malta?
Yes, it's true. I had the opportunity to do the critical care transport course at the time, and this is when I met you. And I did the flight paramedic course, certification course at the time.
That's right. The original IBSC board certification exam for flight. And did you do both? You did flight and critical care?
Yes, I became registered in both afterwards. Especially the critical care was afterwards, so I was not successful at the time. So I repeated afterwards and became registered as well as a CCP.
You've been in the periphery for a while, and you've enrolled in our master's program. You're speeding through that, and you're first to submit your thesis, and then you're also interested in the DHS, which I believe you're starting in September.
It's correct. So the master degree has a lot of things related to that. So I had another studies, and I decided to do a master degree because being a flight paramedic and a critical care paramedic, especially in countries like UK, Australia, New Zealand, they all require masters. And I decided to do it because of that reason. And then when I saw the masters, Corom, so it was one of my options. The other option, believe it or not, was the pre-hospital critical care with the University of Stavanger in Norway. Believe it or not, I applied for both, and I got accepted in both, and I started doing both master degree at the same time. Yeah, it's a stupid thing to do. But as soon I realized that the Corom was better for me, and the reason was I could study and do the master in my own pace and develop, evolve. So I end up quitting the one in Norway and dedicate exclusively to the austere critical care.
It's quite interesting. So you're the only person walking the planet that has experience in the only two critical care master's programs that are focusing on out of hospital. One was pre-hospital, and then ours is austere. So I'm glad that you chose ours over the nothing against the Norwegians by any means, but
no, it was a no-brainer actually because I had to go to Norway several times. I did my application, got accepted, but because of my current job, I couldn't go and be present the days they were asking me to, and so because Corom. The online was quite robust. I could do the online training and everything else during my spare time. That was a no-brainer for me. That's the reason why I carry on.
Nice. And then you did the critical care week in Malta as part of our program.
True. Actually, if you go back in time, it was a lot of things happening. So I at the time I was. If you go back a few years back, I was in Portugal working with the ambulance service and also with the fire service, and I wanted to do more. So I want to become a paramedic. So I did end up in Denmark and did my EMTP. I finished the EMTP in 2013, and then I moved to UK. And while I was waiting for my HCPC registration, I had the opportunity to do the critical care transport. And I said, okay, that's now the good time to do it. So I did the course. And when I moved back to UK, I finished my application and the HCPC recognized me. I said, I started working as a paramedic in the United Kingdom.
Nice.
So actually the critical care transport helped me to do it.
You worked in the UK. What were you doing in the UK, and what was your job like?
So when I joined when I moved to UK, it was 2014. when I got my registration, I was working with South East Coast Ambulance Service, and also I did some work private and so forth. So because I want to gain as much experience as possible. So today I'm still working for the ambulance service with Southwestern Ambulance Service. I've been there since
Mm,
2017 because I don't want to lose connection with the street, with the pre-hospital
right.
environment. And actually, I'm quite grateful for Southwestern Ambulance Service because actually they sponsor my BSc, so I'm quite grateful for that.
Nice. So you're still a bank paramedic in Bristol, is it?
Southwestern Ambulance Service would be Somerset, so the west part of England.
Nice. Nice. So how do you manage that if you're living in Saudi Arabia? So you'll have to tell us about your job at the moment and what you're doing there.
Okay, so I'm a flight paramedic and critical care paramedic, working with a company called Alpha Star. Okay, Alpha Star Aviation Service is a private Saudi company. So we are a national provider for the fixed wing air ambulance in Saudi Arabia, and we work alongside our sister company THC. THC stands for the Helicopter and Jet Company. And what we do to provide clinical crews for the work. So together, we currently operate around 20 helicopters for HEMS,
Wow.
for emergency medical service, and also intra-facility transfers, IFTs. We also have 3 airplanes to do mainly IFTs as well. Our client include many different government agencies, and most are Saudi giga projects such as NEOM or Red Sea that I don't know if you've probably heard
Mm,
of. Um, we have been busy, quite busy. Last year we transported, let me have a look. I've got something written somewhere. 1,639 patients,
wow.
including neonatal, pediatric, medical, and trauma. And we also do specialty team transfer, they call it, such as ECMO and organ recovery.
So I've been there. I've been to Red Star back in 2017, I think it was. They brought me over to run a ITLS course for them and an ITLS instructor course. So I've been in that building, and I remember there's huge cavernous rooms where they have these aviation simulators. Are they still there?
Think so. I'm not going to the office frequently, but I believe they'll have.
Ah, so okay, so you're out in on the
Yes,
flight line, and not yeah. I had to mainly hang out in the office. There's a pretty good classroom there as well.
again, I don't stay there often, so only the stop by as office. So I don't stay there.
So do you stay in one place, or do they move you around to different hem spaces?
So I've been around. I do fixed wing and helicopter.
And are you finding the training that you got from us and from your paramedic program and from your academic training to be enough for dealing with the patients you're seeing?
Definitely. So the training that I received from Corom, joining the masters, and much other training that I did as well, such as other courses, because it was not just the Corom, but masters. They helped me a lot in order to work at the standards that is required.
So this is the second master's. You had a full. You finished a master's before you came to us, didn't you?
Yes. So some
And I don't remember what that was in.
some collect bike, invest in tattoos, other bikes, and other cars. I invest in education, so it's my problem. So if you consider that such.
Yeah. Yeah. So what is your first master's in?
First I did a degree in civil defense in Portugal, and then a post graduation in medicine of conflict and catastrophe. And then I did the first master's
Nice.
was history, defense, international relations. There's nothing to do with medical emergency. And then I did this master's as well.
And you started the other pre-hospital critical care masters. So you've started three masters, finished two.
Yes, yes. Was a kind of hit and miss because I was wondering if I could do the one from Norway. It was quite appealing, but unfortunately, due to my availability, because I had to go to Norway several times, even if it was a part time masters, I was forced to fly. I simply had no time, and that was the issue for me.
So, what have you learned going through our Masters of Austere Critical Care? What memorable take homes are you going to introduce to your clinical practice?
So I learned a lot in terms of critical care. Was more as a broad revision of what I learned before. So from the critical care transfer from 2014 in Malta, and many other courses that I've been doing towards my career because we cannot stop. And the remote or the tropical medicine was also great. The Parasites Without Borders
Hmm.
was a great tool to open and give me more information about malaria and dengue and many other diseases that I normally don't see it. I don't interact with them.
Yeah, I designed that 708 with you in mind, with your skill set in mind, on training paramedics to go out into a ICU and have to deal with a lot of these, like cerebral malaria, that's or visceral leishmaniasis, things that are serious diseases. And do you think you have enough now that you can address some of those issues?
I don't know if I have enough, but at least I've got the minimal foundation in order to go to those places and practice as such. One thing I regret is not to go to the Kilimanjaro, the clinic in Tanzania, to work as a healthcare professional, so to do my placement. But again, it's not forgotten. It's my wishing list, so maybe one day. So it's not forgotten.
That's something you can do at any time. You can do it. You can arrange that with us, and we have other places as well. Kumasi, Ghana, and we used to have South Africa, but we can't go there anymore. It's a bit dangerous. But yeah, that's something you can do later.
Okay, it is something that is my mind, and I'm looking forward to
Good.
it.
And what about some of the other modules in the MSc? The 702, which is all about the austere ICU, where I had 26 guest instructors coming in. How was that?
Seven, it was quite interesting. It's quite interesting. All the modules, especially focus on critical care, they're all interlinked. So we were covering a lot of ARDS and pressures, also the arterial pressures and all the pressures within the heart was quite interesting and were all interlinked. So it was good. The videos were great to help us to understand in depth about what was required for us as a critical care and give us a provider and give us all the information we wanted. So for me, I have no nothing to say against it. So it was great and give, as I said, gave him it was a revision what everything that I had before since 2014 was my first contact with the critical care world. Uh, and he works as a support for what I'm doing today.
Nice. I've learned on my travels throughout austere environments that ICUs located in district hospitals are still critical care. They're still ICU, and the concept of austere ICU is the same concepts of having to deal with ARDS or sepsis or something that you do in London, but you're now in a place where you don't have a lot of kit. So it's all critical care, but it's just been a challenge to design this master's degree to address all those same issues, but without reliance on a profound amount of technology. And it's still a work in progress, of course.
Absolutely. I believe that in terms of being a paramedic and a critical care, it's that there's a step forward, and actually, it shouldn't be the distance shouldn't be that big. So in UK, in other countries, they make it quite clear that what the scope of practice of paramedic can do and the critical care paramedic can do. and I don't think it's useful for a patient, especially in remote locations. And as you rightly said, dealing with a critical patient for instance, with sepsis in a place where it's quite busy, especially when the hospitals cannot accept a patient straight away, and we stay hours and hours inside the ambulance with the patient. We see the patient deteriorating. We can do nothing about it. It's quite similar to working, I presume, working in a remote hospital when we want to transfer the patient for a highest level of care and we simply can't. So we need to work a little bit like MacGyver and try to use the skills that we have available in order to keep the patient alive.
Indeed, I find that challenge so invigorating, that the mental challenge, physical challenge of dealing with the critical casualty in austere environments. And it's so interesting to see how different countries, different hospitals do this. I've been in some hospitals where I wouldn't send my worst enemy because it's just absolutely shocking. And then some hospitals are, most hospitals I've found that are run well, they're spotless. There might not be windows, actually glass in the windows, but they're absolutely spotless and well run. So it's the concept of critical care is the same regardless of where you are. You just got to do the best of what you have.
Absolutely. I we have a saying in Portuguese. It doesn't matter the how the ambulance look like. Could be a very old ambulance. What's matter is the people are inside and the knowledge and experience. We can grab that concept and put it in hospital as well. If we have the right healthcare professionals with the right experience and skills, we may not have the right equipment because it's too expensive, it's not available, but at least they know what's going on with the patient. They can do the best in order to provide the possible care. It won't be the best care possible, but the possible care, right, for the patient to survive. And some thoughts that about we covered during the masters, the prolonged field care, not in depth. I didn't do the course itself, but we covered extensively about the concepts embedded in the prolonged field care. And I presume it's important to apply these even in the normal the pre-hospital worlds in the developed countries that we know. Because as I mentioned, sometimes the patient is not 10 minutes away from the hospital, sometimes it's 1 hour away. And arriving to the hospital, we also have to wait. And 2, 3, 4 hours, and the patient is in your hands, and we're responsible. So we need to provide the best care possible, eventually with some extra drugs or extra techniques in order to keep the patient alive.
Indeed, and you mentioned prolonged field care, which we include in all levels of our courses. But one of the founders of PFC, Dr. Sean Keenan, has a saying that it's people over equipment, and you kind of mentioned that. It doesn't matter what the ambulance looks like; it's what's inside. What are the brains? What are the training? What's the passions? What's the abilities of the patient or the paramedics inside?
Absolutely. And if you work remote places that I've been, so after becoming a paramedic, and I, especially 2019, I decided to go a little bit rogue. So what happens is the NHS increases our salary. We become band 6, was allowing us to do more in terms of urgent care, but less in terms of emergency care. So I decided to leave the ambulance service working full time, start working part time, and start working as an offshore medic, and also been to places like Afghanistan and Gaza,
Nice.
and in Palestine, and even Ukraine, and working those places. Of course, the scope of practice changes, but first of all, it gives you another look, and you start learning different techniques. And we are here for the patient, right? And sometimes the hospitals are different, the way we do things are different, and the outcome sometimes is different as well. So this is important for us to think about, evolve, and to gain as much experience as we have, because if you spend all our career in one place. Again, this is just me. This is my point of view. You spend all our career just one place, doing exactly the same thing, seeing exactly the same faces. Probably in technical terms, you probably won't evolve, and you'll be free. You'll froze in terms of development.
Indeed. So, Alfredo, you're about ready to defend your thesis. Tell us, what is it? I don't want you to go into the full dissertation at the moment, but I'm just curious. Tell the listeners what you're studying and why you chose to write about that.
All right. So I'm going to defend my thesis on the 19th of this month. I don't know if it's going to be open session or not. But on 19th of March, if everything goes according to schedule, I'm going to defend it. I must say it was about triage, and my conclusions were a little bit different from the current views. If you talk to someone about triage, they'll probably have some different views about what my conclusions were. By the way, I need to thank Dr. Jabba about all the support he gave me. It was outstanding. About about triage, just gonna give you a more information about what I noticed that was wrong. So I start my triage studies actually was not with Corona, was long before, it was 2011 when I did my post-graduation in medicine of conflict and catastrophe. It was in Portugal, so a long time ago. At the time, I was taking into consideration my road experience, and bear in mind it was quite limited at the time. But I realized that what we were doing was just wrong. I'm going to give an example, right? If we go to an explosion and a 20-year-old female just walking around and saw the explosion, and she becomes anxious, hyperventilating, and completely lost her awareness. She's completely frozen, looking at the explosion. The first ambulance arriving, probably the first patient that we'll see will be her. And bear in mind, she's not even involved. But because she lost her awareness and breathing fast, they're going to categorize as a red, as a priority one, because she's breathing fast and she lost her awareness, which is simply not correct. During my studies, I managed to identify 163 different types of triage. We can see it's a lot. Not all can be applied to the pre-hospital environment, but most of the ones we are used to work, such as START, or CEV or MPTT24, they've got their faults. And my study was mainly to create a scenario that was already published and test those triage systems using that case scenario. And of course, I came up with some conclusions. Yeah, it is in a nutshell. Is that I realized that most of the studies were private beforehand was based on military casualties between the age of 18 and 35. But of course, the militaries will have a lot of experience dealing with multi-casualty incidents or victims or casualties of combat, right, or firefighting. But it's always between 18 and 35. When we go down to the pediatric age or go up to the geriatric age, we're forgetting a lot of other factors. Patient taking beta blockers won't change the heart rate, or pacemakers, and many other factors. Pediatric, of course, heart rate and the respiratory rate are going to be higher, and many other factors that we don't see them in healthy and fit military from the age of 1835. That's, in a nutshell, that's what my work was about.
I look forward to seeing. I'm going to be a fly in the wall in the room, but it's going to be interesting to hear your thoughts on this.
Okay.
So at the moment, there's this big new thing called the 10-second triage. What's your thoughts on that?
I study it, and actually it's not too bad. But in medicine, we have two things we need to consider. First of all, medicine is not an accurate science. Okay, 1 + 1 is never 2. Okay, always never 2. So if you give a medication to someone, it may work or may not work. is
Mm.
and that's why we have so many different medication and to treat the same problem, because the patients are different, right? Some patients have allergies, some don't, and they react differently, right? When we go for those two, because actually was 10-second triage was published with two triage systems published at the same time, funny enough by the same or almost the same authors. I'm not going to the details because it's better not to, but what I can say is one pretty much the same of the MPTT24. We just included age, the pediatric approach. I have a pediatric approach. Is the patient below the age of 2? It's got a different treatment. And the 10-second triage, it's too, for me, from my part, is too simplistic. Too simplistic. And when we start looking at medicine, such as one size fits all, it goes it does the what they call it under triage and over triage. We may over triage a lot, so we start giving P1s to people who actually don't need it, and we start under triaging patients that is going to lose their opportunity to be saved because we made the wrong decision. Got to give you a quick example. So you go into a fire, right? And most of the most of the healthcare providers use their own on triage system. And someone comes out from the fire, like a structural fire, and they inhale some overheated air. What will happen is they are walking. So if they're walking, their walking wound will be classified as P3, is green. However, 10 minutes later, they're going to develop angioedema and it will go into respiratory arrest and then to cardiac arrest. So because we're unable to use our clinical judgment to see, okay, this patient always walking, it can be a P1. Now, if you go by just blindly following the algorithms, we eventually going to under triage this patient with horrible consequences. But I can give you many more examples from a patient walking with just a second chest wound and the same thing, or the lady that I just mentioned, the explosion, that go back to P1 when they're supposed to be a P3. There's several examples when we can clearly see where we're under triage or over triage patients, and because we're not using our experience and clinical judgment, that's where we're going sideways, and we may fail. Yeah, and that's it in a nutshell.
I'm looking forward to hearing that, and then you're going to publish this. Where are you? Have you figured out what journal you're going to go with, or are you going to write a book, or what are you going to be doing with this?
So I already typed or wrote a lot of articles per se, but I'm a peer reviewer into journals. But the point is, I realized that every journal's got their own way to accept the work. So it will be just 3,000 words normally and with a certain format. What I realize is most of the time when I try to publish something, it's quite limited, and the readers probably will only get half what I'm trying to pass. And they may end up having the wrong conclusions of what I'm trying to, the information I'm trying to pass through. That's I need to think about it to see what I want to do with all the information that I gather. But we'll see. Only time will tell.
And then you're going to be enrolling in the doctorate. So what's your goal? Why are you enrolling in our Doctor of Health Studies, and what do you plan to study?
So I want to finish my academic pathway, put it this way. So I did BScs, masters, and now a PhD. I tried to do one before, so 2019, so it was just before COVID, but I ended up not finishing for several reasons. My idea, if is the thesis that I'm submitting now is well received, planning to evolve all the knowledge that on the information that I gather, and in order to explore a little bit more other types of triage. I already gave you the example fire, right? There's some triage systems specific for burns, right? For burns, the typical pre-hospital systems that we use, right? The triage system that we use don't cover per se. And for instance, CBRN or ASMAT scenarios, if you have a patient who was exposed, probably we need to deal with that patient depending on what we're talking about, right? If we need to decontaminate the patient, our view needs to be completely different, because if we're going to try to save the most of them, the guys who are going to be decontaminated will be the ones who are less exposed. It means it's going to be the P3 is going to be treated first, because the ones who were severely exposed, the likelihood for them to die will be increased exponentially. So what I'm trying to do with the PhD will be to explore this area more in depth and come up with conclusions. That's what I have in mind. Eventually, my mentors may convince me otherwise, but at the moment, it's what drive me through.
I look forward to seeing how that goes.
Yeah, it's a nice subject, and we start binding all the previous knowledge and previous experience, because being on the road for quite some time, you get in contact with get involved in accidents and multi-casual incidents, and you see if the things that are written, all the process, all the procedures that are in place, they actually work or not. Of course, no one in their right mind will be able to do a trial during a mass casualty, because people are focused on saving the most patients as we can, right? Most casualties as we can. But it has to be done someday, and they will be testing the procedures that I have at the moment, and they're going to realize that actually is not work as it should. It was it's been happening. There's some change has been happening, but we'll see. So only the future will tell.
Nice. So, Alfredo, let's say you're working as a medic in an austere environment. You can only bring 3 items. What do you bring?
All right. So about the three items to bring to a austere environment, I presume. So the first probably will be a water bottle. Why? Preferential water bottle with a filter, ideal with a charcoal filter. So we all need water to survive, right? And as a medic, I'm going to need water to clean wounds, to stop the burning process in case I'm dealing with a burn patient, etc. And if we don't have rivers or lakes nearby, we're going to be a little bit ingenious, like MacGyver, right? In order to try to find water in places such as that normally we don't see it, such as cactus, cutting a cactus and try to withdraw the water, or even the drops from the plants. So we need to be a little bit ingenious to get water, but we need water regardless. The second will be tape, eventual large tape. Why not duct tape if we have nothing else? So with tape, I can use as rope. I can use it to tie branches and to make a shelter, make a bandage, a sling, anything. You name it. So that's probably the reason why we all are carrying tape in our pockets while we're working, right? And the third, I think, will be a penknife. Normally, I would say a tough cut. However, I think in a wilderness, an austere environment, I'm going to need a blade to cut things such as clothing, branches. In the extreme, you can use as a scalpel. Thinking of, for instance, using to drain abscess, or worst case scenario, doing a surgical crike, from cutting the duct tape that I mentioned, or again, worst case scenario, finger thoracostomy. So everything, as long as I've got a blade, something to cut, will be nice. If I could take a fourth, probably, if I could, right, I would take probably waterproof matches to start a fire. So I'm going to need a fire to boil water and eventually to sterilize the blades that I'm using or I'm about to use. Of course, it's possible to start a fire without matches, but I believe it's very difficult, especially if everything around you is wet.
That's true. In my bushcraft instructor days in County Kerry, Ireland, which is just wet, my challenge for my students was finding a way to make a bow drill fire, and it's not easy on a good day. So there's wise choice on that. Alfredo, my final question for you is this. What advice do you have for the remote paramedic, the new nurse, the new doctor who is just starting out on their career in austere medicine?
That's a hard one. I could try to be nice and friendly, but I think what I'm going to say, it won't be helpful if I do that. So I'm going to try to be honest, okay? And it's just me, so blame me for that. I believe that wisdom is a combination of knowledge, so what you learn with degrees and training and so forth, and experience, what you acquire doing patient contact. Okay, especially for medics, I believe, this is just me, that we learn by pattern recognition. What's this? It means that we need to be exposed to critical patients. It's like when I'm going to respond to an emergency call, right? When I arrive to the scene, I look at the patient, right? We can already have an educated guess what's going on, if the patient is critical or non-critical. So if I'm going to a cardiac arrest, just looking at the patient, I have a pretty idea that the patient is in cardiac arrest. Okay, and of course I need to check the pulse, respiration, pulse, and so forth. Do all the BLS/ALS as I should. So no complaints here. So we have to do it. But that picture, the first impression, I think is important. If you think about the pediatric assessment triangle for pediatric patients, I think it supports what I'm saying. The problem is this first impression, right? The partner recognition takes some years to develop, and therefore I advise the new medics, okay, new doctors, new nurses, to spend some time working on a busy ED, in our case, ambulance service, in order to be exposed, okay, to patients and gain that experience, okay, and eventually to do placements in other regions or country before they going to the wild, especially in places that you want to work to.
Alfredo, that's sound advice. I appreciate your input, and I look forward to seeing what you can do on your dissertation.
Okay, thank you very much.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.